Thank you, David. It's a pleasure to be here. Welcome, Reverend Dr. Byrd, Dr. Wolpe. It's such a pleasure to be with you. We had a brief conversation before this, and let me frame this for the audience. We're going to take this conversation to yet another level. Let me begin by asking you to introduce yourselves and a little bit about the organizations you're with. Reverend Byrd.
Thank you, Dr. Salas-Lopez, and good afternoon to all of you who are here present, whose eyes are still open. So thrilled to be here today. My name is Malcolm Byrd, and I am the pastor of Mother AME Zion Church in Central Harlem. It is the oldest black institution in New York State, with origins dating back to 1770. The nature of my work as a clergy person is in many respects the opposite of the many years that I devoted in seminary. 90% of my work is done independent of the pulpit on Sunday. So I'm very much focused on how to get members of my community the access that they need to have a quality life. And that is not just in healthcare, but in every facet of human endeavor, every area of human endeavor. I want my people to be better. And that is the work in which we're committed to at the church and in Central Harlem.
Thank you, Reverend Byrd. Dr. Wolpe.
I'm Paul Wolpe. I direct the Center for Ethics at Emory University. I'm unusual as an ethicist because most of my colleagues are philosophers, theologians, religious studies, and I'm a social scientist. My degree was in the social science of medicine, in social psychiatry, particularly under an NIMH fellowship. And I run a center that's also kind of unique in a number of ways. Most ethics centers in the United States are bioethics centers. Most of the money in ethics is in medicine and life science. But we are a general ethics center with a major bioethics program. And what's great about that is that our programs in legal ethics and business ethics and ethics in the arts and ethics and politics feed into our bioethics program and mutually inform each other so we can have some wonderful cross-disciplinary conversations.
Thank you. So the name of our panel is Equity, Ethics, Navigating the New Frontier. And actually, since we started with Chelsea Clinton and Dr. Kalman, we've been talking about health equity and health disparities. Almost every panelist has mentioned it. And so let me begin with this question. What major ethical, social, or economic concerns do you have with AI today? Reverend Byrd?
I would say that I have a myriad of concerns. I won't give them all to you now. But I would say my primary concern is we have created a space now where we've created this artificial intelligence summer house. And it told everyone that they were going to have an AI summer house conference, but the summer house location. That's nice. There's a segment of our community and of our world who not only have no idea where this summer house is located, but they have no idea that people actually have summer houses. So when I hear conversations about artificial intelligence and this new frontier and the new way of the world concerning medicine, I'm still working around the clock just to get people to trust healthcare enough to go in for an appointment. So I think it's perfectly fine that we're building for 10, 15 years down the road. We have to prepare for something. But there must also be, we cannot forget the commitment that we all must have to ensure that as you're working with people who are advanced technologically and who are willing to embrace this new frontier for technology, we also must remember you can't give a manual on how to use AI to someone who cannot read. Is there a commitment in that local community to ensure that people are brought up to speed? While you're tracking data to determine what a person is eating, I'm looking at whether or not they're eating at all. So how do we bring communities up to speed, marginalized communities up to speed, so that when it's all time for us to embrace what AI means across the board, system-wide, across the board, you name it, that we are not serving the population that gets it while leaving the marginalized community that hasn't had the access behind?
Let me follow up on that, because we had experience with Reverend Dr. Byrd during COVID. One of the things we learned quickly was that you couldn't sign up for the vaccine unless you had a computer, an iPad, a phone with a data plan. And so that just happened recently, where we uncovered that you needed an email to register for the vaccine.
Right.
And some do not have emails, don't have computers. And so talk about your experience during COVID and how you engaged the community in ways that made sense, including educate, outreach, and frankly, leading in your community.
Sure, and thank you for bringing that up. Our congregation lost 22 people to COVID in Central Harlem, and I'll say it again, I'll continue to say it. The friend that the Harlem community had during the height of COVID was the Lord and Northwell Health. And I say that not because I'm sitting on a Northwell stage at this moment. I say it because it's true. There were very few healthcare groups, I will not name any names, but Northwell was the only one that came to the aid of Central Harlem when we were dying in droves. No one, in many respects, most of the large research hospitals were only interested in the data after black people were already dead. There was not an interest in how to keep us alive. And the people in those communities who may not have as much academic exposure to understand what all of this means, they know whether or not their life is viewed as a guinea pig or a lab mice. They know if care is real, they know if care is there. What we learned during COVID was that persons were wanting to get the COVID vaccine and even to get COVID testing. And they were willing to do so because there was first a trusted community group hosting the testing and the later vaccinations, the church. And in the African American community, generally across the board, you can go to any city in this country, and probably in that city, the clergy person in that community is pretty much one of the leaders of that black community. So to make things happen in black America, it would behoove you to engage a religious figure in our context. That's why I'm the mayor of Central Harlem. It makes perfect sense. That was a joke, folks. That was a joke. Wake up, loosen up a bit, loosen up. But what we learned during COVID was that the administrative assistant at the church had to essentially operate as a registrar because we required people to have an email address and to go on to register online, assuming that people could go online. There's a men's homeless shelter across the street. What email addresses were many of those gentlemen using to sign up to get the COVID vaccine? So we had to be open to acknowledging the fact that while we're in here talking about the artificial human and things of that nature, I'm dealing with people who still don't have internet access in New York City. So how apt, what is our interest to whereas putting money to greater AI research down the road, how can we help bring these communities of color up to speed by first ensuring, are they eating well? What are the social determinants of health? Are they employed? Do they have a GED? All of these things factor into how to bring a community up from the depths of lack of access to full inclusion and full access as every member of the human family should have as we progress.
Thank you. As a social scientist who does ethics, your concerns.
So let me start there and move in another direction. I mean, the access question isn't an AI question. 40 years ago when I was in graduate school, we were studying access and utilization and all of these problems. This is a chronic problem of the structure of the United States. And AI is just the latest chapter in a very old story of lack of access and misutilization of healthcare services in this country and maldistribution. I want to step sideways for a second and talk about AI for a minute, because one of the things, listening to the amount I've heard, I think there are some misunderstandings of what AI is in the healthcare context and generally. So I want to make 3 points about AI. The first point I want to make about AI is about this issue, sort of, and that is AI is different than other kinds of technologies that have come before in medicine. And one of the ways that it's different is that if you think of all the diagnostic tests and even treatments that we have developed over the last 50, 60 years, I think of them as information points. So you send in the test, you get back your A1C. You send in the test, or you put on the cuff, you get back your blood pressure, and you have a datum. You have a point. What AI is going to be, that none of these other technologies are, is interactive. It's not just going to give you a piece of information. It will interact with the patient, and it will interact with the physician. And as it gets more dynamic, and especially as it moves home, that is one of the points about AI that makes it different also, is it is going to explode do-it-yourself medicine and at-home medicine. It already is. Our Fitbits are taking our REM sleep cycles and our heart rates and our blood pressures and everything. And pretty soon they're going to be diagnostic, and then eventually they're even going to be treatment modalities that AI is going to bring into the home. Doctors are already complaining that patients come in having Googled their symptoms and telling the doctor what the diagnosis is and what the treatment should be. Imagine what happens when they've got AI programs that do it in a really sophisticated way. And I think, there's some promise there for underserved populations too. Just like telemedicine and other things are beginning to bring more services to underserved populations. But we have to be really careful to make sure that that happens. So the first thing I want to say about AI, it's going to be a different kind of dynamic because it's interactive, not static. The second thing I want to say about AI is something I think people misunderstand about the ethics of AI. I spent most of my career before I really got deeply into AI doing the ethics of biotechnology, genetics, and neuroscience. And what's interesting about those is there are extraordinary ethical issues attendant to them, but nobody who does them has to pay any attention to them if they don't want to. You can spend your whole life doing genetic research, you can work on stem cells your whole life, and never once have an ethical thought. You should, and people like me will say you should, but you don't have to. But what ethics is not extrinsic to AI, it's intrinsic. You cannot develop AI programs and not think about ethics. Because AI is a decision-making technology, and all decisions have ethical implications.
Can you give an example of that, Dr. Wolpe?
You can't, the sort of classic example is automated cars. You cannot make an automated car and not decide who that car is going to hit in an accident if it has choices to hit somebody. Right? Mortgage, there was all of this issue about early AI mortgage screening, that it was redlining. Facial recognition software had to be pulled off the market. All of these because there were intrinsic ethical issues to these things that were not addressed. And that's true of almost every medical AI program. Ethics isn't secondary. It's not just about how it's applied once you have it. It's about how you design it. It's called ethics by design. Ethics is designed into AI programs. Ethics doesn't come in how you apply AI programs. And that's why ethics has to be thought of prophylactically in AI. You have to start with the questions of how you're going to design things, not worry about the ethical application afterwards. And many AI products have been pulled off the market because they didn't do that. And then the third point I want to make was made earlier by one of the panel members, and I want to respectfully disagree. I think AI is going to be a profound job displacer and disruptor. Profound. It's already happening. The difference between the AI revolution and other earlier technological revolutions was they almost, if you think of the Industrial Revolution, you think of the computer revolution, they mostly displaced low-skilled workers. AI is beginning to displace high-skilled workers. It can already read contracts better than paralegals, simple contracts. Some lawyers are saying there won't be paralegals anymore. It already can read skin lesions as well as dermatologists. It can read scans almost as well as radiologists. It's going to be displacing highly skilled workers across the board, as well as low-skilled workers like drivers. And I think there's going to be massive job displacement. And the last thing I'll say about that is one of the differences is when we talk about displacing low-skilled workers, we talk about retraining them. It's a very different thing to talk about retraining radiologists and dermatologists. What does that even mean? So I think we underestimate how disruptive this technology is going to be across the board in its application, in its impact on jobs, as well as the possibility that it actually could help serve underserved areas in ways they haven't been served before.
Thank you. You know, we talked about access quite a bit today.
Yeah.
In fact, Dr. Barakat was talking about access to clinical trials and including diversity. LaShonda just talked about that as well. I just recently learned that we're putting the first cancer center in Queens. Never been done before. One of our communities that we've identified as very vulnerable. And then was something interesting that was said, I think, by the CEO of Eli Lilly, that AI could be used to improve access, but it could also, unfortunately, be used to block access, if you will. Not that we want to think that that's how it's going to be used, but how is the democratization of care and how is the use of AI, in your experiences, going to help us with access and improving care? Dr. Wolpe?
Well, I mean, I think there are examples already. I think telemedicine is one of them. But I'm involved in a grant that has just been granted to look at the ethics of robotic surgeries. You know, robotic surgery is going to be able to, you'll be able to take a robot arm that you can actually control remotely and do surgery at a third at a remote location. You may be able to install these, widely. Now, is that ideal? Is that really what you want? No, but I mean, compromise is part of this. It's part of, trying to bring people to the point where we can give them the kind of care that we want. So between telemedicine, between home-based care, yes, many people don't have access to these things, but there are also, I remember being in China 15 years ago with my daughters, and I was looking out on a field, and there was a man there with a ox in a rice field. I mean, it was a picture that could, if you had been there 2,000 years ago, you would have seen exactly the same thing, except he had a cell phone on his belt. And I thought to myself, it's reaching the farmers in the rice fields of China, these cell phones. It was just a revelatory moment. Technology can trickle down in that way, and it takes some time, but there can be access. There just has to be the political and the economic will to make sure that those kinds of devices and those kinds of technologies reach the people, often who need it more, than the well-resourced.
That's great.
And thank you so very much for that. It's a very good point. I think that in the right now, in a community and context of Central Harlem, where I live and work, in a community that means a great deal to me, there are 1,000 primary care physicians in the Upper East Side. 1,000, over 1,000 actually. There are approximately 100 in Harlem.
Sobering.
Meaning that if you are suffering with an ailment, it's very possible that your undertaker will get to you before your doctor has the time to get back to you. So it is my hope that AI advancements, particularly through telemedicine, can assist my community in at least getting some answers for the medical challenges they may be experiencing, to know whether or not to take that to the next level, perhaps in a hospital or what have you. But there must be a consideration concerning the economics of this. Who's going to train persons to know how to use, let's say, telehealth or telemedicine? Who's going to assist in providing either a smartphone or a tablet to show someone how to go on there and actually do it? I think for pharmaceutical groups who are here, for foundations that are here present, for medical groups that are here present, may I make a suggestion to you? Partner with the people who are already on the ground, who understand the context of the community when it comes to bringing communities up to speed enough for them to grasp the benefits of AI. I'm not anti-technology. I'm anti-technology that won't work for my people and won't work in the context of my community. A QR code means nothing to someone who can't read.
That's so true.
Or someone who doesn't have an access to a smartphone. Last thing I'll say, I promise, I'll say this, last thing. I received a call from a large internet provider group a few weeks ago, and they mentioned they were partnering with a national black organization concerning internet access in marginalized communities. And this is a very interesting point. It was made known to me that I was very surprised to hear. They have research to show the significant gaps in Wi-Fi access based on block and street in New York City. The block where my church is considered a internet dead zone. And it makes perfect sense, because when it was time for Northwell to come in to set up their system for our COVID testing and COVID vaccination clinics, Northwell Health had to bring in their own Wi-Fi service, because for whatever reason, it would not work in the 100 block of West 137th Street. I'm not making this up. So to say to someone in that community, this will work if you just go onto this website, sign up here, you can have a chat bot, all of this stuff, that doesn't mean a damn thing to someone who doesn't have Wi-Fi.
That's true.
So what do you do? Oh, excuse me for saying that, pardon me for who's ever watching. So what must you do? You must first bring the systems up to par. So as you're working on helping to educate a person on how to use this stuff, you must first work on the system. So for those of you who are here, I want everyone to know Central Harlem needs some systems rebuilding. And if you're here and looking for ways to ensure that AI will make sense to marginalized communities, the best place to determine if this will work is Central Harlem. Start now, because 10 years from now, there's no telling where we'll be. Start right now, so we'll both end up in the same place together.
That's awesome. Thank you. Reverend Byrd is not shy, as you can see. And you talk about something that's important, partnerships. And so I do want to end, given the audience and what's been talked about, I do want to end on a positive note. So what message would you leave with this audience with today that you think will have the greatest impact on the health and well-being of our community going forward? I'll start with you, Dr. Wolpe.
So I'm involved in a group that meets a couple of times a year, and these are sort of .com executives, the heads of startups, and they have a certain kind of techno-utopian view of the world. Technology will solve all of our problems. You name the problem, and you get smart people thinking about it, and they'll create a technology that will solve that problem, or at least address that problem. And they systematically, but they live in a bubble where people are technologically savvy and technologically sophisticated. And they also live in a bubble where people are technopositive. I think we saw in the COVID epidemic that, having a vaccine wasn't enough. We had a vaccine, and large swaths of the American public refused to take it. And so creating the technology is just one step. As we know, yes, you have to create the technological structure, but there's also human work that needs to be done. There's also conversations that need to be had. There are good reasons why populations in our country don't trust medicine. Really good reasons. And it's not just the African American community. I spent a long time working with the Native American community, and they are deeply distrustful for very good reasons of this culture and this society in general, but of medicine in particular. And so there's a lot of work to be done if these incredible AI creations that we hope to make, and even the ones that are specifically made with all of the right reasons to try to cater to the underserved and poor among us, just creating technology isn't the end of it. It's just one step in a complex social enterprise that has to be undertook to restore relationships between medicine and many different kinds of communities in the United States, as well as building up the infrastructures and the institutions to serve them.
Yeah. Thank you. And I know that we touched upon the partnership and the importance of, in parallel, in addition to the infrastructure that's needed, creating the right partnerships and working and establishing that trust. So whatever it is we're building in the future, it's done with the community, not to the community, but done with the community. So your final words to this group, Reverend Byrd.
As we continue a conversation on what is this artificial human, as we look at what is real and what isn't real, I want you to know that there are 200,000 people in central Harlem that are not a figment of any of our imaginations. They're real. Whereas you must gather data from them to know what best services to provide, how best to address issues concerning their care. That's wonderful. But remember that they are actual, real people. And the worst thing you could ever do to an already marginalized person is to fancy an artificial lab creation over their real flesh and blood, with experiences, with heartbreak, with loss. They are real people. So as you gather information about how best to serve them, remember that's a real grandmother. That's a real grandfather. It's a real human being. So let's not get stuck in a world where we are creating something that might come while ignoring the challenges people live through each and every day upon terra firma. Thank you.
Thank you for a wonderful, honest conversation on equity, ethics, and the new frontier.
Thank you.